Bob Kaplan used to head up health services research at UCLA, and was our first PI of the Right Care Initiative, heading up the GO grant that helped us start our pilot in San Diego.
Great. Can you hear me?
Yeah. Yes, we can.
Great, thanks. Hattie, thank you. And it's good to see all of you. I can see many of you sitting around the tables. So get the slides up. First of all, it's a pleasure to still be involved with Right Care, even though from the other coast. And I do hope that I'm able to make it back to one of the meetings sometime soon. Hattie contacted me a while back and asked if I could say a few words about what the NIH is doing with regard to stroke and stroke prevention. So I'm going to talk a little bit about some of the programs just briefly today. And let me begin by just telling you a little bit about the NIH. For those of you that don't know our structure, we have a very simple administrative structure here at the NIH, as you can see in this slide. There are 27 institutes and centers around the NIH, and I work in the OD, or the Office of the Director. The NIH has 4 substantive area offices within the Office of the Director. One is our office, the Office of Social and Behavioral Sciences Research. There's also an Office of Research in Women's Health, an Office of AIDS Research, and an Office of Disease Prevention. And actually, we as offices and as associate directors to the director work very closely together, and many of the projects that we work on are relevant to the prevention of cardiovascular disease and stroke. So I do want to say that we are still in business, although the NIH, as many of you know, has been impacted by the sequester and some of the other budgetary limitations that we're experiencing in government. So we have not had a budget since I arrived in 2011, and we have lost about $2 billion in funding for grants over the last 6 months or so since the sequester began. So I apologize to many of you who are competing for NIH grants. We know that the competition has become very severe. But it is worth saying that we still are issuing grants in a large number of areas. The NIH had a budget in 2011 of about $31 billion. And within that, about $5 billion, or about 16%, goes to our intramural program. And then the remainder, about $26 billion, goes out to institutions like yours. That's about 84% of our budget. And with that, we support about 325,000 scientists throughout the United States and in some other countries. And we support about 3,000 institutions. Now, the mission statement of the NIH involves science in pursuit of fundamental knowledge about the nature and the behavior of living systems. I think that that's what most of you think of as the core mission of the NIH. That is the basic science component. But it's also worth saying that there's a second clause to our mission statement, and that is the application of that knowledge to enhance life, enhance health, lengthen life, and reduce illness and disability. And this second clause is quite important to activities like the Right Care Initiative and the Million Hearts Program and many others that involve applications of what we've learned through basic science and clinical science to improve the lives and lengthen the lives of people in our population. So Hattie did ask me to say a little bit about what the NIH is doing in relation to stroke. And I just want to say that I'm not going to go through all of these projects today because I only have a few minutes, but it's worth saying that the NIH has a very robust program in the epidemiology of stroke, primarily focused in the National Institute of Neurological Disease and Stroke. And so this slide just lists several of the major cohort studies that are in play. And I think it is also worth mentioning that we have a very robust activity in health disparities in relation to stroke. And we have 3 stroke prevention centers nationally. I emphasized in red that 2 of the 3 are in California, one at UCLA and one at UCSF. We also have a health disparities advisory panel and a variety of other activities that are centered around eliminating disparities and health outcomes related to stroke. The NIH also has very robust activity in clinical trials, primarily funded by the NINDS, but actually several of the other institutes are involved as well. This includes pilot projects, phase 1, 2, and 3 studies. And again, we are thinking about future directions, which might include a large randomized community-based trial combining primary prevention with that of acute stroke prevention. There are quite a few NINDS-funded phase 3 stroke prevention trials. And again, I'm not going to go through all of these, but just to mention that several of these studies have been completed and they're reported in the scholarly literature, and then some of the other ones are currently in play. And the slides will be available for you, for members of the audience that want to look up some of these studies. I did want to emphasize, though, that we have gone to an open science policy at the NIH, so results from these trials, the ones that have been completed, are available for reanalysis, as are the results from the epidemiologic studies. So those of you that are not involved in original data collection, there are abundant new opportunities to reanalyze data that have been collected in all of these different studies. This is just a continuation of a listing of just some of the stroke trials. It is worth saying that some of these trials have produced unexpected results. The Sampras Trial, for example, the second from the bottom, is an interesting one. Now, not so much on the stroke prevention side as it is for people who have established disease, but this is a trial that looked at stenting versus aggressive medical management, primarily using antiplatelet drugs and aspirin for the treatment of prevention of intracranial stenosis, treatment of intracranial stenosis. And the interesting part of that trial is that they used something like what's used in aggressive management of the prevention of stroke. They worked with identified populations, called them regularly, got them in for care. Now it turns out when they did that, then aggressive medical management actually did better than stenting in this particular trial. So I wanted to just take a few minutes to talk about some of the things that we're particularly interested in here in this office. We are very interested in behavioral and social determinants of health outcome. And so there have been a lot of different analyses in the literature that have looked at the proportion of the variance in health outcome that's associated with medical care as opposed to factors outside of the medical care system. And there are about 60 different published studies in the literature at this point. And across studies, it appears that about 10% of the variance is associated with medical care, and probably 40 to 50% is associated with these behavioral factors. So when we look at the epidemiologic literature on stroke, it is worth mentioning that a variety of studies suggest that these behavioral factors are quite important in the prevention of adverse outcomes associated with stroke. So on the upper left portion of this slide, which summarizes a big epidemiologic study in Finland, they looked at physical activity in relation to development of clinical stroke over the course of time. And you can see that there's a systematic rated relationship between the amount of regular physical activity and the probability of developing a clinical stroke. Or the lower left portion looks at smoking status. This is particularly for hemorrhagic strokes. So smoking cigarettes, people who were never, ever, or current users of cigarettes, there is a very systematic relationship. Those who are current cigarette smokers have about a 2.5 times higher risk of developing a clinical stroke, or hemorrhagic stroke in this case. And then on the right side, this is a vegetable consumption portion. This is all self-reported, but those who eat more fruits and vegetables, but in this case primarily vegetables, have a significantly lower probability of developing a stroke. Now, two comments I wanted to make that we found to be particularly interesting, and one has to do with where strokes are occurring in populations. So where you live does make a difference. This slide is not a stroke slide, but it's one that has really gained our attention. In this particular study, David Kindig from the University of Wisconsin looked at life expectancy changes for women in 2 time intervals, the interval between 1992 and 1996, and then later between 2002 and 2006. And in some areas of the country, like these ones in blue, life expectancy actually got longer for women in that interval. And by the way, it is worth saying that going back to the beginning of the last century, life expectancy significantly increased each decade throughout the 20th century. And it continued to in these areas of the country. But these green areas, there was no gain. But remarkably, in these red areas, which turn out to be 47% of the, or 42% of the counties in the United States, life expectancy for women actually declined in that interval between 1996 and 2006. And it turns out that this area of decline is very much like areas where we see greater incidence of cardiovascular disease and stroke. So this slide summarizes what is referred to as the stroke belt. And the stroke belt has a deep footprint in the Deep South. And as you might remember from last slide, it is actually very much like the areas where life expectancy was declining for women in that area. So we know that a variety of other factors related to location are clearly correlated with probabilities of deaths from stroke. Now, I'm just going to mention quickly one of the very important epidemiologic studies on stroke, and this is the study that's called REGARDS, headed by George Howard from the University of Alabama in Birmingham. This study has produced a lot of interesting results in the last few years. One of them is just to re-emphasize this difference in the hazard ratio of having a stroke early in life for black and for white men in the United States. So that the darker line represents the probability of stroke adjusted for a variety of other risk factors by age. And as you can see, particularly for men in the 50 to 60 year age band, the probability of having a stroke can be about 5 times higher for black than for white men in this time interval. One of the other areas that we become very interested in is patient-reported outcomes and how patient-reported factors might be crucially important in predicting stroke. In this particular slide, Howard and his associates looked at a variety of factors like self-reported TIAs and memory loss, a variety of other factors, symptoms that might be related to strokes. And the reason we think that this is particularly important is that lots of people who see their primary care physicians come in complaining about these issues, but are actually never formally worked up. And in this particular study, you can see that these self-reported symptoms have very good predictive value in terms of future stroke. In fact, some of the newer data coming out of that study show that memory loss is actually quite a profound predictor of near-term stroke. This is, again, from the study that, again, having diabetes as opposed to pre-diabetes, another very good predictor of these stroke symptoms. So, I think I'm about out of time, so let me try to wind down quickly, just to say that when we look at factors that predict stroke, some stroke epidemiologists say that 3 major factors are blood pressure, blood pressure, blood pressure. So that when we look at people in the United States who are aware, treated, and controlled for high blood pressure, only about 80% of people in the National Health and Nutrition Examination Survey who have high blood pressure actually are aware that they have it. And among those, only about 70% are treated. And among those, only about 50% are controlled. So that if you multiply this out, just more than a quarter of people who might benefit from intervention are actually getting that benefit. And when we analyze it another way, we're, of course, here at the NIH very, very interested in developing new molecules and better drugs. But actually, if you look at simple interventions like behavioral reminders, in this case for cholesterol medications, the return on investment may be 7 times better for investing in better implementation and dissemination of proven principles than in developing the next generation molecule, even though we're very, very high, of course, on developing those new molecules. So I think I'll just skip this. This is just to say that we are getting better over the course of time. The number of people whose blood pressure is controlled is improving. So what are our future directions here at the NIH? Well, one is that we're looking for new studies on the impact on the treatment and quality of life with regard to stroke and other cardiovascular diseases. We're very interested in the impact of vascular risk factors on cognitive decline. That's an area that we expect to increase in the next few years. The problem of health disparities is just not going away, and so we are interested in more studies that will help us understand disparities and hopefully eliminate them. And then finally, common data elements. We're very interested in harmonizing what's measured in studies, so that we can get more information from the studies that we're funding. So by way of summary, we were out of work for a while, but we're back and happy to be back at work. And for those of you that are applying for NIH grants, certainly the NINDS, the National Institutes of Neurological Disease and Stroke, and the National Heart, Lung, and Blood Institute are the institutes that are doing most of this work. But don't forget about a variety of other NIH institutes that are very interested in this area. So the NINR, the National Institutes of Nursing Research, is also funding research in this area. The National Institute of Child Health and Human Development, particularly for those who have already suffered from a stroke, is quite interested because they have a whole rehabilitation center. The National Institute on Aging and the National Institute of Deafness and Communication Disorders also has a portfolio relevant to stroke. So thanks again, Hattie and others. Thanks for inviting me back. And it's a pleasure to see the progress that's going on in the Right Care Initiative. You want to come back if you have questions?
I'm happy to.
Can they?
Bob, I don't think there's
Yeah,
any
can we hear them now? So if you have any questions, and Dr. Wright is here as well. I'm not sure where you are on the agenda.
We're about 15 minutes behind, so if we
I'm
could,
sorry, okay.
no. If we could email you our questions and maybe have you respond that way.
That would be great, Steve.
Okay, thanks a lot. It was really terrific. Great update. Thank you.